I will shed my speaker hat, I meant my session co-chair hat, and put on the speaker hat. Okay, so I'm Matt Springer from UC San Francisco, and thank you all for sticking around for this last session, this last talk of the session. So I'm going to be telling you about work that we've done in my lab we've been doing this for about 15 years, I think, looking at bone marrow cell implantation into post-MI hearts in a mouse model. And as you know, this has been the story has had its ups and downs over the years in the field, and so I'm going to tell you what we think is going on and what we're doing in my lab right now. So first I want to acknowledge the people in my lab, and let me get this, there we go. So the people in my lab currently, and also various people who have been in the lab in the past and collaborators who have participated in the work that I'm going to tell you about. Okay, these are my disclosures. I have no disclosures. I have some spousal disclosures, and I'm not actually used to saying that because I just got married a few weeks ago. So I'm not sure if I'm doing this right or not, but hopefully I am. So I don't think I need to tell you too much about the sordid history of bone marrow cell therapy for MI. There were papers in the like 2000, 2001 time that reported that if you took bone marrow cells and implanted them into post-MI hearts in mice, a bunch of them turned into a lot of cardiomyocytes, and this was a transdifferentiation effect. And to make a long story short, there's a lot of debate about that. Some of the original work is in question right now, and we don't have to belabor that point. But basically, the concept of this is that the patient's bone marrow cells are going to be harvested after MI and administered back to the heart. And this gave way to numerous clinical trials that have had really mixed results. Some of them have looked somewhat promising, others haven't. It's still being debated now, I think, whether this is really having an effect or not. And actually, during the heyday of this kind of therapy in the humans, the big question was, how is it working? Is it working by the cells being stem cells, or are they working by a paracrine mechanism? But I really have to say that the question more now has been, does it work? Because so many of the clinical trials really didn't show very good results. And I think that some of them did show reasonable results. I think there's something going on there, because when you do this in rodents, it's very therapeutic, actually, regardless of the mechanism. And a number of groups have shown this. So what we did, this is an old slide, some of you might have seen it before. When I came to UCSF in 2003, my collaborator in the division, Yerim Yegiazarians, and I developed a way to use high-resolution ultrasound to guide injections into the mouse myocardial wall. And so you can see here a representative image. We're putting the needle into that thin wall of the beating heart. And we can actually use this to target the infarct border zone and implant cells where we want to put them without a surgery. So this means we can do the implantation several days post-MI, at times more clinically relevant to the therapies that are being worked on. No second surgery involved. And so I'm going to summarize several years of work in one slide, mash it all together, because this is old stuff. Background for what I'm going to tell you about. We use this to show that if we put bone marrow cells, unfractionated bone marrow cells, into the heart after an MI, we got an increase, an improvement in left ventricular ejection fraction compared to vehicle control. We got benefits in infarct size, benefits in vessel density in the border zone, and a reduction in apoptotic cardiomyocytes. But interestingly, when we killed the bone marrow cells first and injected a cell-free extract, that was therapeutic too. And as a matter of fact, if we injected green GFP-labeled GFP-expressing bone marrow cells and looked for green cardiomyocytes after a month, they weren't there. There were no green endothelial cells or anything. Most of the cells were gone, and the few cells that were there looked like maybe dendritic cells or something like that. So we concluded that the bone marrow cells were having a paracrine effect, and that basically all you had to do was implant them, and all they had to do was die. And that would give you your therapeutic effect, regardless of what everyone else is doing trying to get the cells to survive. So we published that in 2009 in Molecular Therapy. So since then, my lab has been looking at what these differences are between the rodent models and the human experiments because, again, there's something going on. There's some good stuff if you're a rodent that's not translating into being a mouse, being a human. And there are a number of differences between rodents and mice in the way that these cells are delivered. But one thing that we felt people weren't really thinking about very much was that in the case of mouse models, you can't get bone marrow out of a mouse without killing it, basically. So what people usually do is they take syngeneic mice and they take cells from one mouse, donor, bone marrow cells, and implant them into the post-infarct heart of another mouse. And those donor mice are usually young, healthy mice, for reasons of convenience. But in the envisioned human situation, these are patients getting their own bone marrow cells, and they're typically older and post-MI. And so they're getting old post-MI donor bone marrow cells. We do not put young, healthy bone marrow cells into old post-MI patients in these clinical trials. And we certainly don't put juvenile bone marrow cells into them. And in these mouse models, the mice are pretty darn young. So we reasoned, well, what would happen if the disease state or the age was making a difference to these bone marrow cells? And we decided to test and see what would happen if we compared implantation of bone marrow cells from mice of different ages, young, middle age, and old, and also if we compared implantation of bone marrow cells from healthy donor mice and from donors that were post-MI themselves. The recipient mice would always be constant, and this is something you can't do with humans. So a lot of this work was done by Xiaoyin Wang in my lab. Junya Takagawa started the project. And so first, let's look at the MI. So this has been published a few years ago, so this is still background for the rest of what I'm going to tell you about. But Xiaoyin did some nice experiments where she looked at cells taken from healthy versus infarcted donor mice, and you can see that the cells taken from the post-MI donors were therapeutic, but less so. That they were somewhat impaired in their therapeutic efficacy. And we saw, again, differences in recipient wall thickness. So again, we're always looking at recipient cardiac parameters after implanting these donor cells. So this is recipient wall thickness, recipient LVEF. So we were trying to figure out what was going on, and it became apparent pretty early on that since MI is a robust inflammatory event, presumably the bone marrow of someone or a mouse who's had an MI is not the same as a healthy individual. You've got a post-inflammation bone marrow. And so we decided to look closer at that and see if the time course of inflammation was affecting what we were looking at. So this is what the inflammatory result looks like, the inflammatory response looks like in humans after an MI. We decided to look in several ways to see whether the time post-MI that you took the cells would affect the therapeutic efficacy. And so Xiaoyin did this massive experiment. Every one of those colored lines is a group of recipient mice. And you don't really have to try too hard to interpret what you're seeing there, because I'm going to take this graph and I'm going to turn it around so you're going to look and see what those day 28 results look like. And you can see that the longer we waited after the MI, first, the efficacy of the cells went down to about 3 days post-MI, and then if we took them at longer times post-MI, the efficacy went back up, which is what you would expect if this is related to an inflammatory response. We further looked just at the recipient, at post-MI hearts, so these are the donor hearts, to see what kind of inflammation is going on, what's the time course of actual inflammation in the rodent. And we saw just by grossly looking at the extent of inflammatory infiltrate, we saw a similar time course. And I have to say that in the early time points, just the way that we were scoring this, it was difficult to get a signal for very small numbers of inflammatory nuclei. But this was in line with what we would expect to see. And then lastly, we did cytokine array analysis, where for a bunch of cytokines, each one of these peaks here is 4 of them, looking at cytokines in the circulation over that first week. And we saw that for a bunch of these things, the cytokines are coming up and going down in roughly the same pattern as we saw the decrease in our therapeutic efficacy. So, and as a matter of fact, I just want to mention that it's funny how sometimes the kind of data you show starts to look almost like the venue in which you're showing it. It's sort of strange how that works out sometimes. At any rate, this was interesting to us, and we put all of these results together. And you can see that if you look at these thin lines here, these are all the cytokines that came up and went down. And you look at the thick line, that's the development of inflammation in that heart of the donor. And then you looked at the red line, which is the loss of efficacy and restoration of efficacy of the donor bone marrow cells. There was a correlation in timing. So I said, okay, well, this is good circumstantial evidence that this is an inflammatory response-related effect. So then we did an intervention. We tried treating the donor mice, not the recipients, but the donor mice with anti-inflammatories after the MI. And so if we treated those post-MI donor mice with dexamethasone and took those bone marrow cells, you can see that we prevented the impairment of therapeutic efficacy in those cells. And moreover, since when we were looking at the cytokines, we noticed that the largest changes were in cytokines associated with the IL-1 pathway, we decided to treat the post-MI donors with an IL-1 receptor antagonist, and that partially prevented the impairment. So what we concluded from this, and we published this a few years ago in Science Translational Medicine, is that the inflammatory response was affecting the donor cells somehow, and that if you were able to blunt that, you could potentially make these cells better. Now you can't give anti-inflammatories to the MI patients. People tried that in the 80s or 90s, 70s or 80s or something. It weakens the heart wall. But something about the donor bone marrow cells are being affected by inflammation. So we're going to come back to that in a minute. I want to mention that we also did pilot experiments back then looking at the effects of donor age. And so our first pilot experiment, we saw taking donor cells from young mice, middle-aged mice, and old mice, that the middle-aged donor cells are therapeutically impaired, and the ones from old mice are practically useless. And we saw that also in recipient wall thickness. I mean, it's a very similar story to what I showed you with the MI. Now, Song Tao An came into the lab after that as a postdoc, and he really went to town on this. And everything else I'm going to tell you about from here to the end of the talk is work that was actually just accepted for publication in Molecular Therapy yesterday for the special issue on cardiovascular regenerative medicine. So Song Tao did an experiment kind of like what Xiaoyin had done for MI, where each of those lines is a group of recipient mice, and he took cells from donor mice at various ages. And he showed a remarkable progressive nature of the impairment of the cells. Basically, the older the donor mouse was, the less effective the cells were. We saw that in recipient LVEF. It was actually a pretty impressive progressive decline. We showed it in end-systolic volumes and diastolic volumes, this progressive change with age. We saw it in recipient wall thickness. We saw it in recipient infarct size. It seemed any way you sliced it, the older the donor mouse was, the worse the cells were. So we had then two different effects. We had an effect of donor MI and an effect of donor age, and those are very different situations. But we reasoned that somehow there was some commonality to the two. And so we had compared the bone marrow composition in post-MI mice and healthy mice in our previous study. And we compared now the bone marrow from old mice and young mice. And in both cases, we saw a bunch of differences, but there was one difference that stuck out. Actually, the only difference we saw that was the same for both situations was a decrease in B lymphocytes in the bone marrow. So old mice had fewer B lymphocytes in the bone marrow than young mice. Post-MI mice had fewer B lymphocytes in the bone marrow than healthy mice. And we said, okay, well, maybe this is the common thread, even though it might be happening for two different reasons. Maybe the B cell level in the bone marrow is what's accounting for this therapeutic efficacy. So we decided to try taking young, healthy bone marrow and manually depleting it of B lymphocytes, pulled out the B lymphocytes, and injected the remaining bone marrow. And as you can see here, the therapeutic efficacy of the bone marrow cells went down when we removed the B cells. We basically recapitulated the effects of age or MI in the donor by taking out those B cells. So this was pointing at the B cells, and this is interesting because B cells have been shown to be therapeutic in various other related models. They're not quite the same thing as what we're doing, but it wasn't that far-fetched of an idea. Now, of course, for people who originally thought, years ago we were going to be looking at adult stem cells, bone marrow B cells doesn't sound very sexy, but this seems to be where things were going. And so we said, okay, let's try implanting purified B cells, isolated B cells. And we showed that if we took B cells alone and implanted them in our model, we got the same therapeutic effect that we were getting from the unfractionated bone marrow cells. Implanting T cells as a control gave us maybe a partial therapeutic effect, but not nearly as good as the B cells. And the B cells were isolated by a subtractive approach where you don't bind any antibodies to the B cells themselves, but you use magnetic and flow sorting to pull out everything else. And actually, as we were getting ready to publish this, one of the reviewers, and who might be in the room, I don't know, if so, thank you very much. One of the reviewers had a really, really good question, which was, hey, you're subtracting all the other cells. How do you know that what you have left really is only B cells? How do you know you don't have contamination with, say, mesenchymal stem cells, which we know are therapeutic? And this was a great point because in those, when you do subtractive selection for B cells, the markers include all these other hematopoietic cells in the bone marrow, but they don't include markers specific for mesenchymal stem cells. So we did an experiment more recently, trying to get this to show up, here we go, where we did another similar prep of the B cells, and we did FACS analysis looking for mesenchymal stem cells, and in the mouse, you can look for CD105 positive, CD29 positive, SCA1 positive, CD45 negative cells, and that's a reasonable marker for MSCs. And by doing that, we saw no detectable presence of contaminating MSCs in the B cell population. So we can feel pretty confident that we've got a B cell mediated effect. Now remember that in those initial experiments, when we lysed the bone marrow cells, we showed that bone marrow cell lysate alone was therapeutic. And so we did the obvious next step. We lysed the B cells, and we see that B cell lysate, so there are no living cells here, B cell lysate is therapeutic to roughly the same extent that unfractionated bone marrow cells or purified B cells are. And when we lysed the T cells and injected that extract, that was not therapeutic really at all. And so this is not just a general effect of putting in cell goop, it's not Golgi and ER and things like that. Something specific about the B cells. And so what we surmise from this is that the B cells are accounting for at least a large part of the therapeutic effect of the bone marrow cell implantation in our model, which is not necessarily the same as humans. But I think it's very intriguing and indicative, and that this is a paracrine effect. And so I'm going to stop there. And like I said, I'm going to make this short so that we can make sure we get out on time, and summarize what I showed you. So implantation of bone marrow cells, unfractionated bone marrow cells, even if they're dead and lysed into the myocardium at 3 days post-recipient MI, improves cardiac function, limits infarct size. It's generally beneficial. Advanced age or post-MI state of the donor, regardless of the state of the recipient, impairs the therapeutic response of those bone marrow cells. This post-MI therapeutic impairment is involving an IL-1 mediated inflammatory response, signaling from the heart to the bone marrow that causes changes in the bone marrow that makes them less effective. In the case of both age and MI, the therapeutic impairment may be due to a reduction in the level of bone marrow B lymphocytes. And lastly, the B cells are mediating at least part of this therapeutic effect via a paracrine mechanism. Now, I think it's pretty clear that a large part of this effect is being mediated by the B cells. I'm a careful guy, so I'm just going to say at least part of the therapeutic effect. But what seems very clear is that this is paracrine. The cells don't even need to secrete something, and I want to emphasize this at the end because a lot of the cell models that people are looking at, they're emphasizing trying to preserve the function of the cells and preserve cell viability after implantation. And clearly, if you're looking at cells that are really differentiating into cardiomyocytes, that's clearly something you need to do. But if you're looking at cells that are having a paracrine effect, what I think is really interesting about this is that these cells did not have to sit there living and secrete products over time. We had the same therapeutic effect by just killing all the cells and injecting the lysate. That means all the cells have to do is sit there and die. So maybe trying to preserve cell viability is not really all that important if you're doing this kind of an effect. So the last thing I'll say about this is that clearly now the question is, what are the cells making? I'm sure half the people in the room are already thinking about this. It seems that whenever someone has taken an adult cell that has a therapeutic effect in the heart, regardless of whether those cells are capable of differentiating into a cardiac phenotype in the dish, they're almost always working by paracrine mechanisms, and it seems that in cell type after cell type, it's the exosomes that are having the effect. So mesenchymal stem cells, cardiosphere-derived cells, CD34 positive cells, all these groups, it's the exosomes. I've actually been interested in looking at exosomes for several years now, and we're now looking at whether exosomes from the B cells are mediating this effect. So that's work in progress, and I hope to be able to talk about that in the near future. I'll also say we're doing some human studies with collaborators looking at post-MI human bone marrow cells, and the results aren't ready to be discussed yet, so stay tuned for that. And on that, I'll stop and take questions, and thank you very much. So, any questions from the audience?
Lior from Mount Sinai. Beautiful talk. I want to understand, the injection was intramyocardial? Or
That's right. So into the myocardial wall at the border zone.
And did you try to give it like IV and see what happened?
No, we haven't done it IV. I mean, when the point of this is we're trying to put the cells where they're needed. Mm-hmm. So it's hard to do intracoronary implantation, delivery in the mouse. Putting it IV throughout the circulation, one would expect that most of the cells would just get lost in the lungs and the liver and things like that.
Yeah, but if it's a paracrine effect, maybe giving it, and it's protected probably with exosome or something, could be something that you might try.
Yeah, I can't discount that. I mean, I don't really know. It would be quite a dilution, right, compared to putting it where they need to be. But, it's an interesting idea, though. It certainly wouldn't hurt to try, so maybe we'll give that a try at some point. Thank you.
Doesn't the method you use for lysing the cells preserve exosomes?
I would think so, yeah. So the way we're lysing the cells is 3 successive freeze-thaw cycles, and then a low-speed centrifugation, just, the little thing on the desktop to get rid of grossly insoluble material.
So you don't use detergents? You don't use detergents?
No. We didn't want to do anything that would either affect the viability of the function of any molecule's activity, and we certainly didn't want to do something that would harm the heart when we put it in. So it's detergent-free. It's just freeze-thaw. Yes.
Pingguo from University of Texas. Yeah. The question is, I think if you test the lysate of B cells, whether you think about the secreted something from the B cells, because you think about paracrine infection.
Right. Well, so when people have done mesenchymal stem cells, Victor Zhao's lab showed a number of years ago that they were secreting factors, which is relatively easy to do because they're nice adherent cells. We haven't cultured the bone marrow cells, and we haven't cultured the B cells to try to get what's being secreted from them until now, because we want to look at the exosomes from the B cells. So we are going to be isolating exosomes from the B cells in culture. But since the lysate itself is therapeutic, if it's an exosome-mediated effect, it means either that the exosomes are mature enough to work before they're released from the cell, or there's some precursor of the exosomes that are still being made. Whatever it is, it's there in the cell lysate. So I'm not really sure whether there are products that are being secreted from the cells that would work that we're not seeing in the lysate. We just haven't done that.
Yeah. Okay, thank you.
So the B-cell impairment is IL-1 related after infarction, but after upon aging, basically, is it also IL-1 related, or have you kind of tested whether you have an increased IL-1 production with age, or?
I'm trying to remember if we did that. I don't think we did. It would be interesting to look at. Yeah, so I'm not sure. I mean, what we did was we looked at a variety of differences in cell composition data that I didn't show, looking at increases and decreases in various kinds of cells. And we didn't see the similar changes that we saw post-MI, except for the B cells. And so one would think if you have a similar inflammatory response going on, that you'd see more commonalities. But we didn't actually do that experiment. All right, well, so now I return to my session co-chair role and say thank you very much to all of the other speakers. Thanks for coming, and enjoy the rest of the conference. And remember to do the, what do you call it, the evaluation through the mobile app. Thank you.